So there's three things I'd like to cover. Firstly, what we've learned from the MIDAS dataset with a sort of demonstration of our MIDAS GP dashboard. And then thirdly, I want to go on to what we're doing in the National Community MSK audit and database that we're leading at Keele. And our strapline here, you can see the goal: using data to improve outcomes, patient experience equity, and care quality at a fair cost with lower carbon emissions. So that's what I'd like to talk through. And I'm just going to start by talking about why we need this for MSK problems. So musculoskeletal problems, which are our focus as a research group, and I work alongside Kelvin and a number of others I can see that are on the call today. That's things like back pain, knee pain, shoulder pain. It's incredibly common. As you'll know, we think it affects around a third of the UK population. They make up about 1 in 7 GP appointments, which is estimated somewhere around 7-8 million consultations a year. They also contribute to around 2 or 3 million visits to community MSK services and things such as physiotherapy. And the truth is that we've got a lot of data and visibility in the primary and community space. This report that I'm showing here is from our great charity. It's just changed its name to Arthritis UK, but they do a really good state of musculoskeletal health report each year. And in that, there's a section on access to care. And at the moment, that just focuses on orthopedic secondary care and rheumatology secondary care. And actually, because of the data invisibility, doesn't speak at all about those 10 million people that are accessing primary and community care services. And yet, there's a context where there's some concern around how MSK patients are being treated. So patients are telling us it's getting harder and harder for them to get an appointment in primary care. They're getting less and less treatment when they see physiotherapy. We know that the morale of both GPs and the MSK physiotherapy workforce is low, and the Department of Work and Pensions is concerned because of how musculoskeletal conditions are impacting on people being absent from work or out of work. And compared to a lot of other long-term MSK conditions, which are often got the GP quality and outcomes framework around them, we haven't got that for MSK. And that means that sort of routine data on what's happening and that intelligence around what's happening for these conditions is largely missing. So that data poverty problem is really what we were set out to try and address, particularly in the MIDAS project, which I'm going to talk to you about now. So MIDAS was a 5-year program. It's actually just finished. We finished in end of September this year. You can see it was a huge team of people involved. It was a place-based MSK data integration program. So our strapline you can see in gold, joining up data and action to improve MSK health for all. So what we were doing was taking data, and actually we got consent on the whole from participants, and we were linking their PROMs and their PREMs from surveys, things like pain and function, with their EHR data on treatment. But we were also collecting A&E and hospital data, and we've got that data now. And we were also looking at neighbourhood metrics and looking at the burden in the population. So we could really see MSK at those different levels of the population, GP practice level, and the sort of MSK service level. And we did that across these 30 GP practices in one ICS. It was close to Keele University in Stoke-on-Trent. And so we set out to really map the prevalence, track the outcomes, what's the access to primary care, what are patients getting, what are the patterns of treatment, and to try and do that all with an equity lens throughout. So I'm just going to quickly touch on 4 insights, publications that have come out of that work that I think change our view of how we should deliver MSK services. So the first one is here is this is work from Ross Wilkie and his team, and we were producing neighbourhood level maps of MSK pain in the community. And this is actually Staffordshire, and you've got Stoke-on-Trent is the area where you can see that much darker red. And what we were doing was just mapping from population surveys the prevalence of chronic pain and high impact chronic pain. And I guess why this is important is it just really highlights the variation and how population need really concentrates in certain areas, and that's where we need to be targeting our improvements on our public health. Another thing is we were looking at inequalities in MSK patient access to see their GP and the improvement they get. And we were measuring that with the Musculoskeletal Health Questionnaire. I've put a visual of that on the left-hand side. But on the graph, you can see what we've done is we've plotted the MSK HQ, so that musculoskeletal health on the y-axis and time along the x-axis, for when patients are seeing their GP, baseline 3 months and 6 months. And as you can see, we've split the mean MSK HQ score by deprivation quintile. And you can see that people in the more deprived areas, they've got actually a worse baseline MSK status. That's a lower MSK HQ score. And they were actually getting smaller improvements over time. So that inequality gap was around 6 points at the start, changed around an 8-point gap at 6 months. So it certainly wasn't closing after the consultation. If anything, it was widening. And I guess that really highlights that we need to be doing more than just providing equal access in primary care. We really need a proportionate effort as the need and complexity varies so much across populations. Thirdly, I'm just going to highlight we developed a cost and carbon calculator for the MSK pathway. And here we're just presenting 6 months of data from MIDAS in the primary care data set that we've got. And we did this in collaboration with York Health Economics Consortium, one of their sustainability experts there. And to do that, what we needed to do is have this really detailed MSK relevant code list, easily categorize the electronic health record data from the GP practices. And on the right, you've got the share of the costs coming from different aspects of the MSK pathway. And you can see that the costs are being driven by GP appointments, imaging, referrals, both routine and urgent. But on the left, the sort of pie chart is very different. That's the share of the carbon footprint coming from the same aspects of the MSK pathways we present in terms of colours for the cost. And the thing that you'll really notice is that medication is a huge driver of the carbon emissions and carbon footprint within our primary care pathway. Interestingly, we've also found that around 13% of patients on average are sort of locked into being frequent primary care attenders, mainly because they're being prescribed certain medications, things like gabapentin and amitriptyline, not particularly evidence-based, but they require regular monitoring and dosage adjustments, and that's really a driving regular appointments. It's also not shown here, but we looked at the cost and carbon value across different GP practices and found that varies widely. Some spending twice as much as others on average on their MSK patients. And where we really want to go forward is to look at the sort of high cost, high carbon hotspots, particularly those that don't provide much value to patients in terms of health benefits. And that's where that work will hopefully go next. Lastly, I just want to show you this result from looking at the sort of the two things of the access to care. So up on the left-hand axis, the y-axis, we've got the proportion of patients who are consulting with an MSK problem in a GP practice. And along the bottom, you've got the prevalence of chronic pain in the community that we've got measured. And you've got 30 dots for the 30 GP practices. And what we were looking at is there a correlation when there's a lot more sort of pain prevalence in the community? Are we seeing that means you get higher consultation rates? But unfortunately, the line's nearly flat, and absolutely there isn't a strong sense of that direction and that association. And that suggests that the pockets of need in our populations, in our communities, that's just not translating through into primary care and better access. Okay, so those are some examples of some of the publications that have come out. Seeing the variation is one thing, but using that is another. So what we've been really trying to do is develop a tool, and it's a dashboard that kind of takes all the data that we had from MIDAS, and particularly from the general practices, and presents that in a very easy to use tool that allows you to learn what's going on. It's not about name and shame. But it is about giving the data back to the public and to into the hands of those decision makers. So I'm going to quickly switch from here to actually showing you what the dashboard looks like, because it's quite interactive. So hopefully this is going to work. What you can see here is we've got some indicators on the left-hand side. So long-term opioids, proportion sent to physio, specialist referral, imaging, frequent attenders, and proportion of MSK patients given a fit note. So I can click on any of those and I see the variation here in the caterpillar plot across the 30 practices. You can see here we've got filters by all sorts of different things. You can have a look at the time trend here. So this presents every 6 months, so Jan to June 2018 right through to Jan to June 2023. And you can hover your mouse over any point and sort of get numbers, if I can show you like that. So you can see how many people we're talking about consulting and how many were given an opioid. And you can then start to look at, well, what's the interaction of, let's take IMD on who gets an opioid long term. On the right-hand side is the breakdown of things like the age categories, and here you've got the different sorts of pain sites for musculoskeletal, multi-site pain, back, hip, knee, etc., etc. And you can click on, so this practice up here that's giving loads, we can see, well, what's happening over time. So if I just take that filter off, so the light green here is that GP practice. Here's the mean across all 30 GP practices. So they've been high in terms of their opioid prescribing for a long period of time. And you can see they're the green ones, the blue is the mean. Now, it's just really helpful. One of the big stories we've seen is this page, which is about actually, it shows us the breakdown in terms of consultation rates and access. And the big story here is the huge drop off that happened with COVID, and that hasn't really recovered. I can show you a good practice that has recovered, steep decline at COVID, bounced back up again. There's lots of practices that hasn't happened. And one of the more detailed things that we can look at is we can go in and see, so for practice 16, I'll just take an example, their medication is high, the norm for their MSK patients, their imaging is high. And we can sort of look into that and say, okay, so what are they doing that's giving such high neuropathic pain? Oh, it's the gabapentin, or on antidepressants. Okay, they're giving lots of amitriptyline. And imaging, what are they doing? They're high on imaging. It's the X-rays and the CT scans. So you can sort of build up a picture. Right, I'm going to just pop onto my talk again and hopefully go through the last bit. So just back to here, and then I'll finish. So what we're wanting to do is to turn that prototype into live data, and to add the cost and carbon piece to the dashboard I've just shown you, so that we can really do the triple bottom line of sort of outcomes, cost and carbon together, as well as the equity lens. And we have submitted a project to do that, and we'll hear hopefully on that. But the last thing I just wanted to tell you about was our National Community MSK audit. So what we're doing with that is we've got both an NHS perspective around 55 different services organizations have signed up to that, and we've got a private equivalent database happening, and that's got about 700 private clinics. And what that's allowing us to do is to collect data both on the sort of patient survey side and on treatment data, to build some national indicators, set some benchmarks, and start to build dashboards just like the one I've shown you. That's the next task for us here, so that we can give the data back to each clinic, and they can see how they're performing compared to others. What are they doing well? What are they doing less well? At the moment, we've really got to define what good looks like as a team. So we're trying to get clarity on quality and what our quality indicators are for the community sector. We started to collect data, and we've got over 130,000 from the NHS starting in January. So it's really, the data's coming in. Each month we get another 20, 30,000 patients. It's going really well. And our future vision will be to connect our primary and our community MSK data sets together. And I'd like to say that the architecture that we're using here is largely condition agnostic. And I do think it could be extended to other long-term conditions. So if you're working on any primary care dashboards or NHS analytics or the green care piece, do link up. And I just finished by saying, I think for too long, what we've been doing is our research has just flowed into publications. And I think what's innovative here is trying to make sure that what we're doing now is building dashboards so that that data can flow back to the public, to the clinical leads as sort of really clear, safe, decision-ready intelligence for them to act on. And I'm going to finish there. So thanks, Kelvin, for that.